Great, thanks very much, Katie, and thanks everyone for joining. Let's get straight into it. So the Family Nurse Partnership, or the FNP, is an intensive home visiting program for vulnerable young mothers, where they receive a home visit from dedicated family nurse every other week from pregnancy until the child's second birthday. So it's quite an intensive home visiting program. It's been rolled out in over 130 local authorities in England, and in these local authorities, with an active FNP site, all first-time mothers aged under 20 at last menstrual period are eligible for enrolment. Now, this is one of the home visiting programs with the more solid evidence base, or one of the ones with the strongest, evidence base, stemming originally from 3 randomized control trials, which were conducted in the US, although these were non-independent trials, so they were conducted by the same team who were implementing the program. But these 3 trials showed evidence of effect on some important maternal and child health outcomes. However, there was some sort of inconsistency in terms of they found evidence of effect in some years, but not others, and in some trials, but not others. But it's still a robust evidence base. Off the back of this evidence, the FNP was introduced in England in 2007 with the aim of improving child health and development among children of teenage mothers. And it was then followed by the Building Blocks trial several years later. Contrary to the US trials, the Building Blocks trial showed no evidence of effect on primary outcomes, and these included birth weight, child hospitalizations in the first 2 years, and maltreatment by age 6. However, it did find evidence of effect on some secondary outcomes, and these included language development as reported by the mother at age 2, school readiness at age 5, and key stage 1 outcomes. So some evidence of effect on important cognitive outcomes there. Now, our study is going to use, or is using, administrative data to evaluate the FNP. And you might ask, rightly so, if a randomized control trial has already been conducted, what's the point of doing another study with administrative data this time? I think there's several ways in which administrative data will enrich the learnings from the Building Blocks trial. And most notably, because we use administrative data, which is routinely collected, it enables us to have a much larger sample size. So the Building Blocks trial enrolled 1,600 mothers, whereas we now have information through administrative data linkage on over 114,000 teenage mothers who gave birth between 2010 and 2017. This increased sample size gives us more statistical power to detect smaller effects or effects on rarer outcomes, which the Building Blocks trial might have been underpowered to detect. It's also going to enable us to look at subgroup effects. So even if there was no evidence of an effect on certain outcomes among the whole cohort of teenage mothers in England, perhaps it did have an effect on some vulnerable mothers. And this is particularly relevant because the US trials found that the benefits of the FNP were concentrated among mothers of low socioeconomic status. Having access to administrative data also enables us to look at who is enrolled in the FNP in this real-world context. The last point here isn't related to administrative data, but I thought it was also important to point out that the Building Blocks trial enrolled mothers in 2009-2010, and this was before a lot of the sort of funding cuts related to austerity came in. And we know that in the 2010s, there's been quite a lot of cuts to health visiting services and Sure Start centres. So we know that the usual care that's available to teenage mothers who are not enrolled in the FNP has changed. And that also might explain if we found some differences in the effects compared to the Building Blocks trial results. So what have we done? So we started by using hospital admissions data from the HES database to construct a cohort of all first-time teenage mothers giving birth in England between 2010 and 2017. We then linked this to the FNP information system to identify in this whole national cohort which mothers were enrolled in the FNP. We then linked this information to educational and social care data from the National Pupil Database, which enabled us to add in sort of more maternal characteristics and look at a broader range of maternal and child outcomes. So our first objective was to look at enrollment in the FNP. And overall, we found that in our cohort of teenage mothers giving birth between 2010 and 2017, just around 24% of eligible mothers were enrolled in the FNP. And by eligible, we mean mothers who live in an area and are pregnant at a time when there was an active FNP site. The map on the left here shows that there was quite striking amounts of variation in the enrolment rates across local authorities, which ranged from 11% in Cumbria to 67% in Wandsworth. And it's perhaps worth noting, that although all these mothers are technically eligible, of course, there's restrictions in terms of the number of places that are available, and this explains some of the variation within England. We were then interested in finding out who is enrolled, and we found that young maternal age was by far the strongest risk factor for enrolment. And you can see from the first line on this table here, the mothers aged 13 to 15 were almost 5 times more likely to be enrolled than those who were aged 18 to 19 at the time of birth. There were other risk factors that predicted enrolment. For example, here you can see that mothers who had a history of mental health related hospital admissions were 1.5 times more likely to be enrolled than those without such a history. However, the effect is much smaller than the effect of young maternal age. And this fits with what we've heard from FNP sites, which is that whether explicitly or implicitly, many of them have policies that prioritize the youngest mothers who are also known to be vulnerable in many other dimensions. We were interested in better understanding the variation in enrolment rates across sites. And for this, we used funnel plots, which are useful for this purpose. And you can see on this graph, each blue dot represents an FNP site. And they're mapped across the x-axis against the total number of eligible first-time teenage mums in their catchment area. And on the y-axis, you can see the enrolment rate in each site. The orange line there shows that in this age group of 18 to 20-year-old mums, about 18% of them on average are enrolled in the FNP. The funnel plot limits here, which sort of these lines here, show the sort of expected range of variation that you would sort of expect to occur by chance. And here what we see is, because we have a large number, in fact, the majority of sites fall outside of these funnel plot limits. And this indicates that there's substantial variation in enrollment rates, which is not explained by chance. So in other words, there's evidence of substantial differences in enrollment rates across sites. And the interesting pattern is that when you look at the sort of smaller sites, so those with smaller populations of teenage mothers in their catchment area, these tend to have much higher enrollment rates than average. Whereas sites where you have more than 1,000 eligible teenage mothers over the sort of time period of our study, these tend to have enrollment rates which are closer to 10%. And it suggests that there's a sort of deficit in the number of FNP places that are commissioned in these areas with large absolute numbers of teenage mothers. And we found less variation among 13 to 17-year-olds, so that was sort of more standardized, but 13 to 17-year-olds also represent a smaller proportion of all teenage mothers in England. So now our second objective, after looking at enrollment, is to look at what is the effect of the FNP on maternal and child outcomes. And we were hoping at this point to have preliminary results to show you. However, unfortunately, we only just managed to get all of our data into the same TRE last week. So we're not able to show you preliminary results, but we will show you some intermediate steps and what our plans are for this next part. So I think the challenge that we have with administrative data is that you can't directly compare the outcomes for mothers who were enrolled in the FNP and those who were not enrolled in the FNP. Because as we saw with the logistic regression model, mothers who are enrolled in the FNP are more likely to be younger and they're more likely to be vulnerable. And we know that these mothers also have independently worse outcomes for themselves and their children. So a direct comparison of outcomes between these two groups might lead us to think that the FNP is bad for mothers and their babies, which definitely not the case, but it's more due to the confounding in maternal characteristics. So in this context, propensity score matching is a useful tool to sort of help use administrative data and make a fair comparison in a context where we don't have randomization through a trial. So the different steps involved in this include constructing a logistic regression model with FNP enrollment as the outcome variable, very similar to the one I showed you earlier, although we'll be adding in a few more maternal characteristics. Using this model, we predict for each participant and each control mother, the probability of enrollment in the FNP. And this probability we call the propensity score. We then, for each mother enrolled in the FNP, we select a matched control with a very similar propensity score, or similar characteristics, in other words. And lastly, we can then compare the outcomes between the matched participants and controls, because knowing they are very similar, we can be more confident in attributing any differences in outcomes between them to the FNP. And so, very briefly, we calculated these propensity scores, and so you can see their distribution in yellow for control mothers and in blue for FNP participants. You can see that on average, mothers who are enrolled in the FNP tend to have higher propensity scores than controls, which we expected. And it's important to note that we have quite a good range of overlap, so a quite long range where we have many, both mothers who were enrolled in the FNP and those who weren't. You can see, however, the higher ends of the propensity score range, that there are many more FNP participants than there are controls. However, luckily, the propensity score matching allows us to match with replacement, which means that each control can be matched to more than one FNP participant. And of course, we then take that into account in the analysis. So this is my last results slide. So just to show you briefly, this graph now shows you the distribution of propensity scores for all mothers enrolled in the FNP in blue, and overlaid on top the propensity scores for those FNP mothers who were matched and therefore included in the cohort, the final study cohort. And you can see that, as we expected, we have about 1.3% of mothers at the upper end of the range who remain unmatched. And this might not sound like a lot, but because they are the more vulnerable mothers for whom we think the FNP is more likely to have an effect, we were very keen to retain those in as much as possible. And we could do this by slightly allowing mothers to match to a control mother with a slightly further away propensity score. So we've widened the caliper to 0.05. And unfortunately, we don't have enough time to go into the details here, but just to say that even when doing this, the mean difference in propensity scores remains very slow, and we've managed to reduce the percentage of FNP mothers unmatched to 0.3%. So we're including 99.7% of FNP mothers in our final study cohort, which is great. And our next step will then be to add in educational and social care variables here, and then producing the impact analysis. So please stay tuned for that, and we'll share them as soon as they're available. And just a very quick summary. So our study found that only 24% of eligible first-time teenage mothers were enrolled in the FNP. There was considerable variation in enrollment rates across FNP sites. And I sort of dislike the term postcode lottery, but I think in a very real way, where you live affects what kind of services you have access to as a teenage mother, and there are very important implications for equity for this. And in particular, we find that there's insufficient commissioning of FNP places in local authorities that have large numbers of teenage mothers. Lastly, we were able to construct a closely matched cohort of FNP mothers and their controls to conduct our evaluation using administrative data, and we hope that this can be a model that can be used for evaluation of other policies and early years services. So thank you very much for listening. Apologies for going slightly over, and I will now hand back over to Katie.